This is coping with treatment-related side effects with Deborah Winkeljohn. She received her Bachelor of Science of Nursing in 1987 from the College of Nursing at UNM. She completed her Master's Science of Nursing in 1996 from the College of Nursing, also at UNM. Since graduating from her BSN program, she has worked solely in oncology. Currently, she is working with New Mexico Cancer Center. She has her advanced certification in oncology and has been working in this field for 35 years. She is involved in national organizations in oncology. She loves to read, enjoy her dogs and her goats. Welcome, Deb.
Thank you. Hello, everybody. Welcome aboard for our discussion today on coping with treatment-related side effects. As Kathy said, I do work with the New Mexico Cancer Center. I've been there for about 4 years. We're going to be talking about a lot of symptoms and recognize that these symptoms come from a lot of issues. It's not just one thing. The cancer itself causes issues, surgery, chemotherapy, radiation, even a lot of the medications we help to prevent some of the symptoms or help with the symptoms cause other side effects. We're going to talk about some of these symptoms and a few more. So appetite loss is probably one of the #1 issues that a lot of patients and their families bring up. Multiple reasons come about for why people don't have much of an appetite. One of the biggies is that cancer itself sometimes puts off a hormone that makes people not very hungry. While you're on chemo or radiation, you can have issues with taste changes, smell changes, you don't have any taste, or things all taste like cardboard. So it becomes very difficult for you to maintain a good diet. With some of the chemotherapy and radiation, patients can also develop mouth sores, a really dry mouth. Some patients are very fatigued and don't want to have to worry about fixing meals. Other conditions also play into it with anxiety, depression. If you're having a lot of pain, can exacerbate your not wanting to eat. So some of the things that we actually recommend for solutions include, if you have the capability, one of the biggest things would be to try to get a recommendation to a dietary company, a dietitian, so that they can hopefully help you maximize the calories that you're going to be taking in. Recommend that you eat about 5 to 6 small meals a day. We do talk about doing protein drinks, whether it's Boost, Ensure. Sometimes I even recommend Carnation instant breakfast with milk, whole milk if we need to. I usually like for people to try to find calorie-dense foods that are in small amounts. I often tell patients that I go through the grocery store and find those things that are small, that are very easy to fix. A lot of times these are not necessarily what we would consider healthy foods, but they can be calorie dense. These are things like we have kind of like soups that are easy to mix in the microwave. We have yogurt in containers. We have cottage cheese with fruit in containers. There are a lot of things that are easy to find on the store shelves that can be helpful. It is helpful if we can do a healthy, nutritious diet. Sometimes, unfortunately, there are not necessarily a lot of calories in what you would call a real healthy diet. The other things I do is try to have your family help prepare meals for you. And if they can, prepare them in small amounts, not necessarily prepare a big meal that you need to prepare. Something that's small, you can pull out of the freezer, you can either put in the stove or heat in the microwave. Generally, a lot of patients do better with room temperature foods than you do with either hot or cold. And some chemotherapies like oxaliplatin don't allow you to eat cold items. The biggest thing I do try to tell patients is to decrease the stress around eating. It's very hard for patients to want to eat. You have family members who are just on the patient, just nagging them to eat all the time. That can create a lot of stress, and it doesn't necessarily help with trying to get them to eat. We have to recognize that we can offer the foods, but we can't ever force somebody to eat. There are medications that are available that can help maybe stimulate the appetite, but they also can have symptoms. If you're interested, you can always talk to the doctor about whether or not there are medicines that can help. Edema is swelling in areas that usually don't have swelling, and a majority of the time it shows up in the legs. A lot of patients call our clinic because now they're having swelling. There are a lot of reasons behind why patients get swelling. There are certain chemotherapies that can cause swelling. Taxotere, cisplatin, with the amount of fluids we have to give, often can cause swelling. But there are other issues, such as if you have kidney issues, if you have heart issues, if you are malnourished, your body tends to want to hold on to water, so you can end up having a lot of edema. If people have ascites, which is a lot of excess fluid in their abdomen, puts a lot of pressure on the blood vessels in your legs, and so the fluid doesn't move as easily. There are things we can help, such as reduce the salt in your diet, try to exercise because that'll move the fluid around. We often talk to patients about keeping their legs elevated instead of keeping your legs down. And then if you want, you can wear compression devices, but sometimes they're just too difficult to get on. The last thing that we sometimes use are what called diuretics or water pills. They can help you get rid of the fluid, but they cause you to go to the bathroom more often. And they also can cause issues with needing another pill, such as a potassium supplement. So again, a thing that we try to help you with one pill causes you to possibly need two pills. In cancer patients, we also check them for blood clots. Cancer can cause patients to have a high risk of blood clots. So if somebody comes in with swelling, especially one leg over the other and pain in the leg, we will get what's called a Doppler of the leg to make sure they don't have a blood clot. Fatigue is found in probably 80 to 90% of our cancer patients. Each time I ask about how they're doing with chemotherapy, fatigue is probably one of the biggest symptoms. And it's really more than just being tired. You get exhausted doing simple activities. Exercise has been proven to help patients with fatigue. And it's something simple as just going on a walk. And I tell patients, I can't tell you how far you should go on a walk, even if you just go out and, around the corner in your street and then come back and then add to that each week. That can actually be beneficial. You want to do your things at the time that you have more energy. Most people have more energy in the morning, and then usually in the afternoon, they really have to sit and rest. You want to limit your naps. Generally, if you're going to nap, you should only nap for about an hour. And hopefully your naps are not going to interfere with your nighttime sleep, because then if you do that, you have more fatigue. If patients have anemia that require a transfusion, then we can offer a transfusion of blood. I recommend that patients try to get help with things at home so that you don't feel like you have to do everything. If you can, try to get childcare help. If you need it home with housekeeping, if you can, get your friends to go shopping for you. Your friends actually want to help you, they just don't know how. And sometimes if they can be the ones to go to the store for you, or maybe even have them come over and help you clean the house or cook meals for you, that is some way that your friends can try to help. Pain is very common in cancer, sometimes coming from cancer itself, or it can come from some of the chemotherapy agents we give patients. The examples of pain from chemotherapy can include Taxol can cause a lot of muscle pain, bone pain, and then long-term neuropathy can cause burning, stabbing, stinging pain. Pain with cancer, if you have like bone metastases, often we use a lot of things like narcotics to help with that. We do have to be careful with use of narcotics because they have side effects. The biggest thing we always worry about is causing respiratory depression. and it can make people very, very somnolent, meaning very, very sleepy. So we really have to be careful with pain medications. We do use other meds, though. We often will use antidepressants. We can also use some nerve agents, such as gabapentin. We also have used steroids in some people to help with pain. Medical cannabis or marijuana is often used in patients to help with pain, whether it's gummies or some people smoke. There are also cannabis salves that you can apply to the skin to help with pain. If patients have a specific type of pain, we can refer to interventional radiology to see if they can help with pain, or we refer to a pain specialist to see if they can give injections, or some patients we end up giving them what's called a pain pump, where they have a continuous feed of pain medications that can help with their pain. The other thing is pain can cause other symptoms. If you have unrelieved pain, then you can have issues with anxiety, you have issues with not being able to sleep, and you also have issues with not wanting to eat. So as much as we can, we really try to help patients with their pain. We also talk to patients about using other things such as relaxation exercises, physical therapy, and even acupuncture. You can also use yoga and Tai Chi. Insomnia means that you're either having issues with sleep, you can't stay asleep, or it's difficult for you to get to sleep. In patients, a lot of them come into this with already having a history of insomnia. Generally, medications are not recommended to be used longer than a week. So when I talk to patients about helping with sleep, I don't go to medication right away. First and foremost, I want to make sure they have good sleep hygiene. That's where we talk about only a 1 hour nap. If you go to bed, you go to bed to sleep or have sex. You don't go to bed to watch TV. You don't go to bed to read. You don't go to bed to stay on your tablet or computer. All of those have shown to cause patients to have issues with sleep. So if you're going to go to bed, you go to bed to go to sleep. I do talk to patients about chamomile tea, sleepy time tea. Some patients find benefit in the use of melatonin. Some patients find use also in cannabis. I do talk to a lot of patients about apps on their phone that you have, but you're going to listen to them. You're not looking at your phone. And they have relaxation exercises. They have help with anxiety. They do guided imagery where they can hopefully guide you into sleep. A lot of them have very soothing spa quality music that can be very beneficial for people to get them to sleep. If patients continue to have issues with insomnia despite a lot of these interventions, then patients can be referred for what's called cognitive behavior therapy, where they have to kind of retrain your brain to get you back into a good sleep habit. Anxiety is very common, especially with a diagnosis of cancer, and then when you're starting therapy, it is very, very common. The anxiety we get concerned about, though, is that it interferes with your ability to get through your treatment or just overtakes your life. Generally, I make a recommendation that you talk to your doctor about your anxiety. Some doctors will use anti-anxiety medicines, but there are problems with that in that they're difficult to get patients off of them if they need them long term. The other recommendation is to try to get you in to see a counselor, a psychologist if we need to. At our facility, we do have access to a couple of counseling services. The other things that are newer nowadays, especially that came out of COVID, is online counseling. There's actually a lot of services online that you can do, and you don't have to travel anywhere to get help with anxiety or depression. Patients also find benefit from use of support groups online. I know a lot of women with breast cancer find women who have had breast cancer, and they find online support groups that can help them with anxiety or depression. We also talk to patients about doing, again, some relaxation exercises. That's where your apps can come and help on the phone, using things like yoga, Tai Chi, exercise, all can also help. Hair loss can be common with chemotherapy, also with some of the radiation. Certain chemotherapies are what cause hair loss. There are also chemotherapies that cause more of a hair thinning. If you have thinning hair and you haven't lost all your hair, we do have patients try Rogaine, which has been shown to help, and we also have patients try the Nutrafol, which is on TV. So we talk to them about how to use those two agents. If you're starting chemotherapy, some patients will ask about the cold caps. You can purchase them and bring them in and utilize them during chemotherapy. There's kind of mixed results that I've seen with the cold cap, but it is certainly something you can use, and we're not going to tell you you can't use it. There are programs. We have one at our clinic on Wednesday afternoons where women can come in and talk about wigs and hats and scarves. Also, I do recommend, usually if you feel like your hair is beginning to come out, then you can go ahead and cut it really, really short. And sometimes that helps it not be so dramatic. A lot of places around town do have wigs, and they can also help with hats and scarves. Skin reactions can be very common with a lot of the treatments, especially with the immune therapies. Immune therapies can cause a lot of issues with rashes. We do use a lot of over-the-counter creams, such as Aquaphor, Eucerin, CeraVe, and generally I recommend creams because they're thicker and they're oil-based, so they help your skin more than some of the lotions. You also have to be careful with the lotions because if they're, scented lotions, they can irritate your skin more. You have to be careful with sometimes showers and making sure your showers are not too hot, because that can exacerbate your rash and your skin reactions. So most of the time we want you using lukewarm water. Some patients will need steroid creams for the rashes. For an Erbitux rash, we sometimes use things as an oral antibiotic and a clindamycin ointment. Some patients with immune-related rashes may also need steroid tablets. And sometimes with a bad enough rash, we have to stop your therapy to get your rash under control. You definitely want to avoid sun exposure. Definitely use sunscreen if you happen to be out in the sun. For certain chemotherapies such as capecitabine, which is Xeloda, or 5-FU, there is a darkening of the skin, especially of your hands and feet. That's very common. With capecitabine, you can also have redness, pain, swelling, and even blistering of hands and feet. That can come from capecitabine, but also Taxotere. If that happens, that generally means we probably need to make some adjustments on your chemotherapy dosing. We also talk with patients about really minimizing manicures and pedicures that can set you up for issues with infection. Mouth sores and dry mouth are very common. We usually recommend, if you can, visit a dentist before you're starting chemotherapy. And there are certain radiations to the head and the mouth that most of the time we would like for you to see a dentist before you start your treatments. While you're on chemotherapy, we also ask you to talk with your doctor about whether or not you should go in for a cleaning. A lot of times the dentists are still using what they call a scaler. I call it the hook, where they have to scrape your teeth and into your gums. That can put you at risk for infection. So definitely talk to your doctor before you go see the dentist. You want to increase your fluid intake. You want to make sure you're not using alcohol-based mouthwashes such as Scope or Listerine. There's Biotine and then Sensodyne. Both have mouthwashes that are much easier. You can use baking soda or saltwater rinses. If you have bad mouth sores, we do have Magic Mouthwash, which we can prescribe. And then if patients get bad enough, we can even do a topical lidocaine that you swish around and swallow. Unfortunately, in some patients who are receiving radiation and chemo for head and neck cancers, they can end up needing hydration. Frequently in the clinic, they have to come in for fluids because they just can't swallow. It's too painful. So know that at least in our clinic, we have that option. I believe in most clinics, they do have an option to bring you in. You want to avoid hot food or drinks because that makes it worse. Also, you have to avoid spices. Nausea is common with a lot of chemotherapies. Most chemotherapies that we're giving you, we will give you anti-nausea meds, but recognize the anti-nausea meds can also cause symptoms such as headaches, constipation, feeling tired. So again, medications, we try to help you with a symptom, cause other symptoms. Decrease the spices in your food. I do talk to patients about using ginger tea. Acupuncture can be used to help with nausea. Patients can also use acupressure bands that they can wear on their wrists. Cannabis has been used to help with nausea. Cannabis also can sometimes help stimulate your appetite. We also sometimes use steroids to help with appetite. We will watch your weight over time and hopefully make sure you're not continuing to lose a lot of weight, especially with nausea. Hopefully, we are preventing vomiting. In this day and age, we really hate to see patients vomiting from chemotherapy. There are a lot of different medications we can try to help prevent vomiting. If you're having issues with vomiting and you're getting dehydrated, we bring patients into the clinic to give them IV hydration and sometimes IV medications to help with the nausea and vomiting. Really, prevention with nausea is the best. I generally tell patients if you're just beginning to get queasy from chemotherapy, you don't want to wait to take your nausea medicine. You want to take it early. And sometimes our nurses teach our patients after certain chemos to take their nausea medicines on a regular schedule to prevent nausea and vomiting. Diarrhea can occur with a lot of chemotherapies, means you're having watery stools, okay? It causes a lot of issues with dehydration. So diarrhea can become a problem for patients. When you call in with diarrhea, our nurses have to be very frank with you and ask you, how many stools are you having? If you just have one, I'm not as concerned. If you're having 5, 6, 7, 8 stools a day, that's a problem. We do make a recommendation for patients to start with Imodium, which is over the counter. If you continue to have issues with diarrhea with Imodium, there are prescription medicines that we can give you to help slow the diarrhea. You do want to avoid milk products. You also want to avoid fatty or acidic foods. We talk to patients about using the BRAT diet, which is bananas, rice, applesauce, and toast. And lastly, if patients are becoming dehydrated, we do bring them into the clinic again for IV hydration. Recommend that patients use things like Pedialyte or water supplements out there that have minerals in them. Because if you're having diarrhea, you're also going to be losing things like potassium. With immune therapy, there can be a symptom called colitis, which generally means bad diarrhea and abdominal pain. That is a phone call to your doctor, no matter what time it is, because that needs to be treated a little differently. And a lot of times we have to put patients on steroids because we fear they have a colitis. This colitis can put a patient in the hospital. So that is definitely a phone call to your provider. Constipation means that you're having very hard stools. Does not necessarily mean that you're going a day without having a bowel movement. Generally, I ask patients what their normal bowel habits are, because there are some people out there who have bowel movements every 2 days. Some women, they can go a week and that's their norm. So I always like to know what your normal habits are before I consider whether or not you're constipated. You definitely want to increase the fluids in your diet, especially water if you can. I talk to patients about utilizing prunes, prune juice, apricots, cherries, anything in the diet that might help you normally have a bowel movement. Some patients use coffee. They can have bowel movements with the use of coffee. The other things I recommend are over-the-counter agents, Smooth Move Tea, Miralax, Milk of Magnesia. All of those we allow our patients to utilize. Stool softeners may be needed to keep your stools softer, and that's fine. Increase your activity level. Exercise helps get the bowel moving, so that is why we encourage you to stay active. The more you sit and lay around, it really slows your gut down. Enemas and suppositories are not usually recommended up front if you're on chemotherapy, because if your white blood cell count drops too low, it's a risk for you to possibly get an infection by doing those activities. So I usually have patients talk to their provider about whether or not they can utilize those things such as an enema or suppository. There can be a lot of issues with memory. Most patients call it chemo brain. Some people just come in and say, I can't remember certain words. I'm having a conversation and I can't think of a word. And that's very, very common. As we get older, we can see this also happening. And as long as it's this short-term memory, you forget what you're doing when you walk into the next room, most of the time I am not as concerned about it. What I do get concerned about is somebody, the patient, if the family members notice that they're asking like the same question over and over and over throughout the day, or they're asking, what kind of appointments do we have? And they ask that same question throughout the day, even though they've been told. The other things I get concerned about is if a patient is driving and they get lost, even though they're in an area that they've driven thousands of times before. That may have me a little bit more concerned about dementia or Alzheimer's and may need further testing. So there is a little difference. Some of the short-term memory stuff is pretty normal. Hopefully, once you're done with therapy, that should get better. But there are patients who don't notice a change in their memory overall, just long-term after treatment. I do recommend all of the healthy things that we've talked about. Healthy eating, hopefully getting enough sleep, decreasing your stress, exercise. And I talk to patients about doing those exercises that can help your brain, such as reading and puzzles. Those help build those kind of synapses in the brain. They're not proven to help with memory, but they certainly can help prevent, hopefully, more memory changes. I do not usually recommend any of the over-the-counter agents because none of those have been proven to help with memory. If I'm concerned that somebody may be moving into dementia or Alzheimer's, then that's going to be a referral to somebody who can evaluate that patient. There are medicines that they can be placed on to slow the progress if they do have dementia or Alzheimer's. Hot flashes are very common in patients who are on medicines for breast cancer and also men for prostate cancer. And it's interesting because I ask patients if they've had a hot flash, and if they tell me, well, no, I don't think so, they haven't had a hot flash. Those that have had hot flashes definitely know what I mean. They can be very problematic. They can hit you at all times during the day and also at night, and they interfere with sleep. There are medications that we can try for hot flashes, but there are not necessarily there isn't one medication that can help relieve all hot flashes. I know they're advertising a new one on TV. Some of our doctors in our practice, I think, use it and others don't. There are other medications, though, that we can try. I also do recommend yoga, acupuncture, and exercise to help with the hot flashes. As far as sexual side effects from treatment, there can be quite a bit of issue, especially with women. They can get a lot of vaginal dryness. They can have a lot of pain trying to have sexual activity. They also have a decreased sexual desire. For vaginal dryness, you can talk to your provider. There are things we can recommend to help. There's things like Replens and Reverie, and I even have some patients talk to us about whether or not they can utilize a topical vaginal estrogen cream to help with the vaginal tissue, because that can actually help women. But you have to talk to your provider. Some providers would prefer women not use the vaginal estrogen. There is also a vaginal rejuvenation where they use a vaginal laser to help rejuvenate the tissue. A lot of times insurance won't cover that though. As far as women and sexual desire, there is really nothing that helps with that. Women have a different sexual experience in that their sexual experience begins mostly in the brain. For men, it's mostly whether or not they can get an erection, and that luckily is easy to fix nowadays with Cialis and Viagra. So men and women are different, and we don't have medicines for women for sexual desire. Men, again, we can use Cialis and Viagra. And if patients as a couple are having problems just with the relationship, then we can refer them to somebody who does sexual therapy. So there are things we can try to help with. Neuropathy is a very common side effect from a lot of chemos. Probably the chemotherapies I can think of off the top of my head that cause neuropathy is Taxol, Taxotere, oxaliplatin. Those are the biggies. It begins as a numbness, tingling, burning sensation, generally begins in the fingertips, usually both hands and both feet, and then works upward. It's rare for patients to develop neuropathy in their thighs, but they don't have any in their feet. There are medications that can help with the symptoms of that burning and tingling sensation. We use things like gabapentin or duloxetine can help with that. There are things that I do talk to patients about to help prevent neuropathy. And now we're using things like cryotherapy or cold gloves and booties while you're undergoing chemotherapy. You can do those with the Taxol drugs and Taxotere, but we don't recommend you use them for oxaliplatin because you have a cold sensitivity. So you have to be sure we know what type of chemotherapy you're doing before we recommend those things. I also do talk to patients about using vitamin B6 and alpha lipoic acid. Those are supplements. Ask your doctor that we use to help maybe prevent neuropathy. We also ask patients with each chemotherapy how their neuropathy is. Is it getting worse? Is it the same? Is it interfering with activities? Activities like putting on earrings, you know, the posts on the back of earrings. Are you having difficulty buttoning clothes? That usually means your neuropathy is getting pretty bad. What we do at that point is sometimes adjust your dose of chemo down, or sometimes we actually stop your chemotherapy. And at that point, either switch to something else, or you're continuing on with part of your treatment regimen. Some people will use medical cannabis to help with the neuropathic pain. That can be beneficial. I also recommend patients use acupuncture. You can use massage. If you have neuropathy in your feet, a lot of patients will get those massaging baths to put your feet in, and they say that can be helpful. After chemotherapy, hopefully your neuropathy will get better. But some patients, I do tell them, neuropathy can stay the same after chemotherapy and not get better, but it really shouldn't get worse years after chemo. If it does, then something else is going on and you need a different evaluation. It either stays the same or hopefully it will get better over time. Osteoporosis is a risk of bone fracture because your bones have become really thin. That happens a lot in women and men who are being treated for breast cancer and also prostate cancer. If men are on Lupron, this puts them at risk for osteoporosis. If you end up with a fracture, That's just a problem because you end up in the hospital, you possibly have to have surgery. And some older patients actually end up being put in nursing homes because now they can't be functional and they can't go back to their home. So in a lot of our patients, we do check their bone health. You get a bone density, looking to see if you have osteopenia or osteoporosis. We also can intervene with medications such as bisphosphonates, such as Fosamax, Reclast, Prolia, Xgeva. A lot of these are very similar drugs. We use them a lot in the cancer population. They help patients hopefully strengthen bones. So we do pay attention to our patients. Osteoporosis is very common in women in general, just because you're female. If you have other risk factors, you have a family member who has osteoporosis, you're a smoker, you're tiny and of low weight, those are all risk factors that put you at higher risk for osteoporosis. And then we put women on medicines that also cause bone loss. Anastrozole, exemestane, all can unfortunately cause women to lose bone. So we do utilize other medicines to help you hopefully prevent loss of bone. Also talk to patients about calcium supplementation, vitamin D supplementation, and exercise. Weight-bearing exercise and or weight lifting can help patients hopefully gain or maintain bone health. There used to be in Albuquerque also an organization called OsteoStrong, which is a different form of exercise to help with your bone health. They actually have machines that exert a huge amount of force on your bones without you having to do heavy weightlifting. I don't know, somebody had told me that they went out of business. I don't know if they're now back in town. So if people don't want to do medication, I would make a recommendation to do OsteoStrong. Hypercalcemia is what we call an oncologic emergency. That means you have a high calcium level in your blood, and it can cause a lot of problems with slower thinking, constipation, nausea, and vomiting. It is an emergency, and if patients have high calcium levels, they're often coming into the clinic to help get medicines to help bring down that calcium. And we usually have to give Zometa or alidronate to help bring down the calcium level. So some patients have gotten phone calls that they need to come back into the clinic to get these medicines to bring their calcium down. Some patients have even been hospitalized with it. Our concern is always risk of fracture. So in my group of older patients, I actually ask them very frequently if they're falling, because just falling is concerning, but also it increases your risk of fracture if you have other issues like metastatic cancer to the bone, or if you have osteoporosis. So the three things to take away today are to talk to your doctor about side effects and how to manage them. I know I've worked at a private clinic, I worked at Loveless Cancer Center, and now I'm working at another private clinic, Mexico Cancer Center. Our docs always want to know what kind of side effects. We have a triage process. The triage nurses can help you manage side effects. And if needed, they can bring you into the clinic to be seen. At our clinic, we usually do have same-day appointments. So if there's something going on, we can see you that same day to try to manage the side effects. I encourage patients to keep track of their side effects. You know, some chemotherapies are 3 weeks apart, and you don't really remember what kind of side effects you had right after chemo. So if you need to, write them down so that you can bring them in and talk to your doctor. And then the last thing is, what often works for one may not work for another. And the other thing that a lot of providers don't like to hear is that you go online and look at Dr. Google to help with your side effects. First thing you should do is contact your doctor's office so that they know what kind of side effects you're having, and hopefully they can help you. Support groups can be helpful But there are some support groups who make recommendations for things that are not usually things that your doctor would recommend. So again, I usually try to encourage patients to contact their providers if they're having significant side effects. So that's the end of the talk. Does anybody have any questions?
Do you know of any foods, supplements that affect the efficacy of anastrozole?
No, not that I'm aware of. Why?
Because I'm on anastrozole and
Yeah.
I
No, in women
had,
who are on anastrozole, I usually don't make a there's no specific dietary changes or dietary things you have to watch out for. In people who are undergoing chemotherapy, there is sometimes a discussion about not utilizing a lot of vitamins and supplements. And I always encourage patients to talk to their provider. Some providers are fine with it, but things like high dose vitamin C, some of the supplements are not regulated, so we don't know what interactions there are. But for anastrozole, no, there's not that I'm aware of. Of course, you're not on estrogen. That's about the only thing.
My question is, my fingernails on my hands and my feet are like, I don't think it's the nails, but it's like purple and dark. And will that go away once the chemo drugs are out of my system?
Are you still on chemotherapy or have you completed chemo?
I completed, the last one was February 28th.
Yes, all of that should eventually go away. There are certain chemos that cause that. Adriamycin's one of them. Sometimes the Taxoteres, Taxol can cause
Right.
that. Darkening 5-FU can also do the same thing, or yeah. So,
Okay, yeah, because I was on Taxotere and
yep,
Cytoxin
yep,
and I do have the neuropathy on my hands, so
yep.
I'm keeping my nails short but I was just worried about that. I didn't know.
Yeah, that should resolve.
Okay, very good. Thank you.
Sure.
When I was getting chemo, I had a hard time brushing my teeth because they were sensitive to the toothpaste and brushing. Is that normal?
Yes, it is normal. And so sometimes, I don't know what kind of toothpaste you were using, but you do try to use the Sensodyne toothpaste. I've even had people use children's toothpaste. I don't think children's toothpaste is as abrasive. You can also use just straight baking soda, make a baking soda paste and use that as a toothpaste.
Question from Marcy. I have severe neuropathy now. Will it get worse with breast cancer treatment?
So you haven't started chemotherapy yet, I assume? Would depend upon what type of chemo you would be getting. There are, adriamycin, Cytoxin generally doesn't cause neuropathy. Taxols do. So depending upon what your treatment is for breast cancer, if that's what it is, taxanes do. So Taxol, Taxotere can cause neuropathy. So yes, possibly.
Hi, first of all, I want to thank you for a great presentation, excuse me. And then I
Sure.
want to ask you, is there a better time to take pills like letrozole? Currently, I'm taking mine at night, and I was reading that it can impact my neuropathy or cause me to feel ill, like keep me I deal a lot with insomnia, that could also be in effect. Is that true? And should I try to switch my letrozole to the morning?
So each one of those drugs, anastrozole, letrozole, exemestane, I, in my years, never made general recommendations about when to take them. But I have found that some women have insomnia or anxiety or something along that line. So doesn't benefit you to take it at night, right? If it's going
Right.
to cause those symptoms. So switch it up to take it during the day. Yes. If it
Okay.
continues to cause problems, then at our office, we'll have you stop that one and switch you to a different one. You mentioned neuropathy. That medicine shouldn't worsen neuropathy.
Yeah, I'm done with treatment. I'm just taking letrozole.
Mhm.
I get terrible numbness and pain in my feet and toes and my legs.
That must be left over from your chemo because your letrozole should not worsen that.
Okay.
Yeah, that should not happen.
Thank you so much for answering my question.
Sure.
I'm on anastrozole and HER2 triple positive breast cancer. Will Rogaine or minoxidil contain estrogen?
No, no, you can use those. They're not problematic.
All right, I think that's all the time we have. Thank you again, Deborah, and we'll see you
Yeah.
again soon.
Enjoy the rest of the conference, everybody.